We're live.
Right. Awesome.
That's how it works. Science. Guys, you will never believe who I was able to con into being on the show today. This is a huge triumph for ZDog Industries because it brings a little something I like to call legitimacy to this dog and pony act.
Hard to do these days.
It is very hard to do. So I have got with me today, and look at this, because I actually got a visitor sticker for UCSF, which is where I trained for medical school and graduated in '99. So it's been like a decade. The guy was like, "Are you in the computer?" I'm like, "Yeah, I'm in the computer." I went here when I checked in, and he was like, "When did you graduate?" And I'm like, '99. He's like, "There weren't computers back then." Like, that's how old I am. I was able to nab Dr. Patrick Ha, who, listen to this background, okay? Nerd Fest, like 2017. Harvard undergrad. Johns Hopkins for medical school, Johns Hopkins for ear, nose, and throat training, and now he is the head of surgical oncology at surgical oncology head and neck at UCSF Medical Center here in sunny, foggy San Francisco. And he is a family friend for many, many years. And when I told him we do a live show, he's like, "Well, you should talk about how head and neck tumors are changing in their epidemiology in a way that, since you talk a lot about vaccines, Z-Dog, you should talk about the fact that HPV is now causing cancers in the head and neck more than ever before noticed." And I said, "Now you're speaking my language," which is genital warts in other places than the genitals. That's how I translated it. That's not exactly what's happening. So thank you. Welcome to the show.
Of course. Thanks for having me.
No, man, it's a thrill. So Patrick took me on a tour of the new UCSF Mission Bay, which I was just blown away.
Yeah, it's amazing.
None of this existed when I was a medical student.
No, it's like every year a building comes up.
Every year. And speaking of buildings coming up, check this out. Okay, again, I'm going to derail this for a second. I got to show these guys this. So we're in a conference room up here at the top of the administration building, and look across the street. Can you tell these guys what is going on here?
Yeah, crazy. So right across the street, that's the new Warrior Stadium coming up. So it's right on the water, right next to our hospital, and it's going to be great.
Lacey Lamana says, "What's up? Up." Yeah, we're pretty high up here, Lacey. Not medical marijuana high, actual altitude high. "Oh boy, bring on the anti-vaxxer," says Aaron Burkhart. It's coming. All right, so we're really excited. And there's a lot of great people and a lot of great research at UCSF, and Patrick is one of the top. So, Patrick, like, what was it? First of all, why did you get into head and neck surgery, and cancer in particular?
Yeah, so I think it's something that I didn't even know existed until my second year of medical school. The fact that there was a whole specialty derived from this, but some of it is that the surgery is great. It's really detail oriented. We're always looking at nerves, and there's a direct relationship of how we operate and how people do. So that's always gratifying to know that our technique matters, and we pay a lot of attention to that. I think the other thing is within ENT, there's a lot of different subspecialties, and so head and neck oncology kind of made a lot of sense to me because we have a very longitudinal relationship with our patients, meaning that when they come and they say, "Well, are you going to see me again?" I'm like, "I'm your doctor for life because I'm going to keep following, I'm going to keep checking up on you," and so that's really meaningful to a lot of us who go into this.
You're sure you're a surgeon?
I know, it's a bridge. It's a bridge.
It's a bridge. It's a bridge to a relationship.
Yeah, which typically we don't like, but actually for these patients, it's really a pleasure. And I think the third thing is that we it's definitely a team approach. So we never work in isolation. Our tumor boards are really robust. We work with medical oncology, radiation oncology, speech language pathology, dental, and a whole other team. So
SLP, dental, the whole team, and when you talk about tumor boards, you're talking about an interdisciplinary gathering where you're talking about a case and trying to find everybody's input. That sounds to me, guys, very Health 3.0. What do y'all think? But yeah, so please continue.
Yeah, no, so I think that matters a lot in the sense.
By the way, Natalie Vincent says SLP here too, so you're giving shouts out to speech.
Yeah, so and it's more than that too. It's nutrition, social work, all these other things. So. But, it basically what it means is that our approach is very individualized and personalized. So, we think about what kind of job they have, how important their voice is, what does swallowing mean to them, how they interface with the world. And so those are things that our surgeries, depend on, as well as if we decide to start with radiation or chemotherapy, then all those things are taken into account. So it means that, every person who comes through, we see sort of through this lens and we have to think about. So it's not just straightforward, "Oh, I see a tumor, let me cut it out," and then you guys figure out the rest. It's sort of this thing we have to do in the beginning, which makes it more interesting.
And so getting that and one piece of feedback I'm getting is we may want to bring the mic a little closer to
sorry.
Patrick, or speak up a little
I'll
bit.
speak up.
Because he's, unlike me, he actually speaks in a normal human voice, whereas I'm constantly shouting. So do you think that the interdisciplinary sort of, we call it Health 3.0, and the way we define it is it's team-based collaborative care that's not necessarily hierarchical. So even though you have a ton more training than me in head and neck, we treat each other as colleagues, as the most important people in service of the patient.
Yep.
But I defer to your knowledge on all aspects head and neck surgical, but at the same time we treat each other as colleagues. Now that in Health 1.0, it would have been very hierarchical. You would basically be yelling at me the whole time and treating me like the loser hospitalist that I am. So in 3.0, getting all the members of the team, and that includes speech, it includes dental too, right? So how do you interface with the dentist? I'm just curious.
So especially for patients who get radiation, they're going to need dental care because the radiation actually weakens the jawbone quite a bit.
Oh.
So they can actually get infections after treatment that comes back to surgery sometimes, where we have to remove a portion of their mandible just because they can't clear this infection. And so we want all that dental care done up front.
Yeah.
And we've gotten even to the point where if we're doing a very advanced surgery, we'll actually have the dental team, oral surgery, come in, remove whatever teeth they have to do while they're asleep, and then we can proceed on with our surgery. So that way the patient doesn't have to go back for like 13 teeth extractions.
That's a great, I mean, and that's great for people particularly who are more scared of the dentist
Absolutely.
than they are of you.
Yeah.
I mean, you're going to basically remove pieces of their mandible, but they're more scared of like a little drilling and a Novocaine injection, right? Because it's an oral cavity and they're awake and so on. Yeah.
And so they need to know that ahead of time because after the case, it's almost too late.
Yeah.
You know, and then you're talking about treatment delays, and then all these things sort of go into a bad outcome.
So to identify all these issues, and say somebody comes with a cancer and you're now planning this out, so does it start with tumor board, or does it start with an interdisciplinary meeting, or does it start with you in the office with the patient?
It starts even before the referral sometimes. Well, not before, as we get the referral.
Yeah.
If we recognize, oh, they're going to need these things, we start to implement the plan. But then definitely when we meet face to face, then we start saying, okay, I'm going to talk about your tumor board, but I want you to see these people ahead of time. And you sort of check off the boxes. So we're trying to streamline that process, and then at the end, try to wrap it up with an educational process so that the patient is aware of what the whole team members are trying to do.
Wow. So, because you're often talking in head and neck tumors about patients who are going to end up with potentially a feeding tube, with a tracheostomy, with some life-changing alterations to how they live.
Yep.
Do you try to talk about this well before you cut?
Yes.
Okay.
You have to. Yeah.
Now, but you have to, but do you think it's just a UCSF or an academic thing, or do you think this happens in the community?
Honestly, I think it's up to the provider. But what often happens is that there's so much information to process that I think sometimes it's the first time they've been told they have cancer.
Oh.
And then to get around, like why do my teeth matter?
So you actually see people sometimes you're giving them the diagnosis.
Yeah, absolutely.
Yeah. And so they've been referred to you or they probably had a biopsy maybe, or maybe not.
Maybe, or they just have a neck mass.
Oh, right.
Or a bump in their cheek.
And you're trying to decide.
Exactly.
Is it a sialolith or is
right.
that,
Yeah,
right,
or is
right.
it cancer? Yeah.
Is it cancer? Right.
So
my mom went through that actually. She had a parotid swelling, and everybody was worried about cancer, and it turned out to be a little stone. Yeah. Yeah, which is common. But I freaked out because
it's scary.
Yeah, I was just going through as a hospitalist all the different things that could happen, and never a good thing with ZMOM. So it's interesting, we're getting some great questions like, how do you find HPV? Do brain tumors also link to HPV? So maybe let's transition now to the subject of this, which is the changing face of head and neck cancer.
Yeah.
And maybe you can speak to that.
Sure, so I'll give a brief outline of it. So this happened basically in the early 90s, late 80s, where people figured out that there's a certain subset of cancers that look different under the microscope. And so HPV-affected cancer cells, they have a very particular appearance, and so they noticed that these looked the head and neck cancers looked similar to cervical cancer. And they had just like this particular cellular appearance on just regular hematoxylin and eosin staining, so pink and purple. Then they sort of backtracked and figured out that, wow, there's actually HPV present. But it took a while for us to realize this and to recognize this as a real entity.
And I guess the question is the HPV riding along as a marker? In other words, is it associative but not causative?
Right. So it took a long time to prove that.
Yeah.
Right? So we and others have done studies looking at what is the quantity of HPV. right? So how many copies of it, is it just like you get a little bit here and there and you detect it, and then it's just kind of, you had a random infection and you happen to have this cancer coincidentally, all the way to staining for the actual virus to look at that and seeing all the little dots within each of the cancer cells, but not in the normal cells. And then looking at the epidemiologic, just sort of across the nation, across the world, saying, are you guys seeing this too? And so basically that sort of all rose up to the point where we now realize that it's prevalent in, so one important distinction is that it's in the oropharynx, which is not something, that's not a common word, but oropharynx to us means in the tonsil tissue, in the back of the tongue, so not the front part of the tongue, and then also sometimes in the nasopharynx, so just behind the nose, there's some tissue there that can be affected too.
So that's where it's living. It's not. We're not talking about the tongue. We're not talking about the cheeks. We're talking about
way back. Yeah.
Way in the back.
Yeah. So it's the part of the tongue that you can't see.
Right.
And so it, for whatever reason, it has a very high predilection for living there and staying there. And then the other thing to keep in mind is that it's dormant for decades. So the infection probably happened like 20, 30 years ago, and then it sort of stays, and the DNA of the HPV virus integrates into the cells, and then it sort of shows itself later on.
So it's a very similar to, herpes virus, a little different, and it lives in the nerve ganglions, but same idea that it's dormant and then reactivates later, or it doesn't reactivate.
Right. So basically, I think the number is something like 90% of U.S. citizens have been exposed to HPV, but it's still a relatively rare cancer. So we're talking about 12,000 cases per year. So
but that's not zero, and that's 12,000 people with life-altering cancer. Yeah.
And then the other thing that we were chatting about was that it is rising. So whereas smoking in general is reducing in the U.S., so head and neck cancers in general are going down, but this is the one subset where it's actually rising in incidence pretty quickly. If you look at the percent increase per year, and then so estimates say that in the middle of maybe around 2025, the incidence will cross that of cervical cancer and overtake.
So guys, listen real carefully. Let me repackage what he just said. It used to be that most head and neck cancer was smoking related, alcohol related, smoking related, et cetera. And now what we're seeing is actually the incidence of HPV associated head and neck cancer has exceeded smoking. Is it exceeded smoking yet?
No.
No, but it's getting there.
It'll take a while for it to get there.
Yeah, because people are smoking less.
Yes.
They're vaping more. What do you think about vaping, by the way?
It's too early to know.
Too early to know, right.
Probably better than smoking if you had to pick a poison.
Right.
But certainly we don't know enough about it. And actually there are a number of NIH grants now that have been funded specifically to look at that question.
Which is good, because now the federal government is actually telling tobacco makers to reduce the amount of nicotine in their cigarettes to non-addictive levels so that vaping can exceed it, thinking that vaping is safer. And the guy who's making these decisions, I forget if it's head of the FDA or whoever, actually has financial interests in vape manufacturers. So we always want to look at the data before we just believe what the government says, and that goes for the FDA food pyramid and all of that. So in any event, what he's saying is that HPV-related cancers are now rising in incidence to the point where they're going to exceed cervical cancers by 2025, potentially. This is a huge deal for many reasons. One is that it's a huge deal because it affects lives. And number two, this may be a preventable cancer.
Right.
How might you think about the prevention angle?
Well, so, and this gets into the hot topic of vaccines. And so it's important to remember that the vaccine, the HPV vaccine, is a preventive vaccine. So if someone comes to us and they're 45 years old, has this tonsil cancer, we're not actually recommending to get the vaccine because they've probably been exposed, or clearly have been exposed.
And that answers Kenneth McKay's question, should a grown man get HPV vaccine?
Right.
It depends what you mean by grown, but what age cutoff would you think people are mostly exposed at that point?
Probably their teenage years to early 20s.
Now, there are guidelines for the vaccine that I think extend into the 20s for women, I think, but really, the minute you have any kind of sexual activity, you're at risk.
You're at risk, exactly.
Oral, anything like that.
Right, so this is not thought to be, it's not a curative vaccine. So basically, I think what I tell my patients is that, no, the vaccine is not going to help you now because you've already developed antibodies and have been exposed. But I think the difference is there is that if they have children, then I should say, you should consider vaccinating them.
Yeah.
So the one thing I will say is that the studies that they did to design this particular vaccine, they were not done to look at tonsil cancer or oropharynx cancer. They were done for cervical cancer.
Right.
So it's basically, we're drawing an association with the thought that it's exactly the same virus subtype. So it's HPV 16 predominantly.
16 predominantly, yeah.
And so that if you have the vaccine early on, I bet we're going to see a decrease in incidence 30 years from now.
Right. Now listen carefully to what Dr. Ha is saying. He's saying he bets that we're going to see a decrease in incidence because he's a scientist. So he's not going to tell you what naturopaths and other people will tell you, which is, this is what's going to happen. We don't know, but from first principles of this vaccine, seeing that it decreases cervical lesions, not necessarily cancers, but intraepithelial lesions, precancerous lesions, seeing that we if we vaccinate early enough and on schedule our young men and women, but looking at women, there are no greater side effects, because I'm getting a ton of questions. Does it cause birth defects? Does it cause this? We see all these reports in the news. And I want to clarify this. There was a recent meta-analysis, too, looking at all the data. There is no greater than placebo incidence of side effects with the vaccine, except for pain at the site of injection and some local redness. And so all the stories you hear of, oh my God, this girl got paralyzed right after the vaccine, or this happened, or that happened, or she started having seizures, she lost her mind. That is called correlation, not causation. We have no evidence that this vaccine causes any of that.
Correct.
Now, we also don't have evidence, as Patrick said, that we can prevent head and neck cancers with this vaccine yet, even though it's the same serotype 16 HPV. And many of the cancers now Patrick is seeing in his practice are related to HPV. But you can start to extrapolate and say, look, if the vaccine has very little downside and potentially could prevent a life-threatening cancer, would you not want to do it, especially for girls, but also for guys?
Yes.
Does that sound about right?
Yeah, and I think that the whole male versus female is, we don't know enough about that in tonsil cancer or pharynx cancer to say what's going on, because actually, even though we think of HPV being a female disease mostly in terms of cervical cancer, actually most of the people who have oropharynx cancer are men.
Right. Now I wanted to follow up on that, because you're seeing this so much at a tertiary referral center, so you're probably seeing the difficult cases and the simple cases both. Are you mostly seeing this in gay men, homosexual men, trans men, heterosexual men? Is there a particular predilection, or is it across?
So as far as we know, in terms of sexual behaviors, it's not necessarily more so in gay or transgender men. I think the main thing that we've noticed, the association, is actually with oral sex. And so that just may be a question of exposure and contact.
Right.
But even with that, it's really mostly in men.
Right.
So it could be, a worse immune system in men that may lead to that.
Right.
But we don't really know enough about the transmission to say, well, why is that occurring, and how can we prevent that, or what is different about it?
Right. So either it's an epidemiological thing where men behave differently sexually, whether they're heterosexual or homosexual or trans or whatever, or it could be a innate physiologic thing with men, right? So something about testosterone, lack of estrogen, having a Y chromosome, their anatomy, their immune system, etc. So it's fascinating. Yeah. Really, really interesting. So when you see so if you were going to say, okay, looking at prevention, which is going to put you out of business, but you want that.
Yes.
Yeah.
Be happy to.
Exactly. And I bet there's plenty of other cancers too that you would treat in the head and neck. By the way, before we get to prevention, what are the most difficult cancers that you treat?
I mean, every cancer can be difficult in different ways. I think so the other take-home, actually, we didn't talk about is prognosis. So actually, if you have HPV-related disease, so HPV-related cancer, you tend to do better.
Oh, okay, so it's better than a non-HPV or a smoking-related.
Yes. Yeah. Because there's something about the genetics of it that make it simpler to treat. Typically, these people have not been smoking, but there's sort of this middle ground where people do smoke and they have HPV-related cancer. They sort of do moderately better as opposed to someone who doesn't have HPV at all in their tumor and smoke and drink, then they're going to fare the worst. So actually, this is an interesting subset, because these people tend to do better to the point where they will move on from their disease, and we'll keep looking at them, but our expectation is, hey, they're done. We're going to be okay.
Wow.
So then it brings up this other interesting thing that we maybe as a field didn't think about so much before. Is that, well, what does it mean to be living with the side effects of your treatment? And so actually the trend has been now to say, look, if we're 85% of people are getting treated and doing okay, then that's a whole group of people who are now, getting radiation, their teeth may be hurting, they may have problems swallowing. So actually we're trying to back off treatment a little bit.
Wow.
And see if we can get the same results.
Wow.
So it's sort of both sides of the coin now, which makes it even more interesting to treat.
You know, and this happened in breast cancer, and this is happening in your field too. And just like, what's the minimum viable
Correct.
treatment that will spare us side effects? And this, we struggle with this in Western medicine all the time.
Right.
How much to do. So that's interesting. So prognosis may be a little better for HPV related cancers. I had a follow-up question for that, because everything from tracheal damage from radiation. I mean, what is your sort of standard packet of armamentarium for treating one of these cancers?
Well, so we have surgery, radiation, and chemotherapy are kind of the three things. So from a surgical standpoint, this is where in the old days, like 25 years ago, everyone would have had surgery up front, which oftentimes to get to that area, we had to cut the jawbone, open it up, and then to get that area, and then make our hole, and then take some tissue from the forearm or the leg or thigh, and then stick it back in there, then close back up.
Wow.
So it's kind of a dramatic operation. People in the hospital for 10 to 14 days. Swallowing is challenging. And so that's when, around the time they realized that treating with radiation and chemo up front might be a better way. And actually, in terms of treatment efficacy, it's pretty much equivalent.
Wow.
So then what happens is that if you look at that surgical group, they often need radiation and or chemotherapy afterwards. So if you present that to a patient, they're saying, wait, it's the same outcome. Why are you cutting open my jaw? And we go, yeah, why are we doing that? So we stopped doing that.
Got it.
So then what happened is that we developed a set of surgical tools through the Da Vinci robot mostly, where we can approach these things endoscopically, take it out, get people out of the hospital in 2 to 3 days. They return to function much faster. And then along those lines of trying to reduce therapy, sometimes if we do that, they don't need radiation afterwards.
Oh, wow.
So if it's caught early enough, then we have the potential for actually reducing their therapy.
The burden. Yeah.
Right, by introducing, a less invasive surgery. So it's not for everybody, and so it's a pretty small, piece of the pie that really we think we're really reducing treatment, and oftentimes it's an option to reduce treatment. So that's the surgery side. Radiation has been a mainstay where it is curative, but also sometimes adjunctive, meaning we take it out, then we realize, wow, this disease is worse than we thought. More lymph nodes involved, or there's something about it that makes it more aggressive, and then we'll add radiation afterwards.
Got it.
The chemotherapy is meant to go with the radiation. So that's when we look at it and go, this is really bad. We really need to add something on top of the radiation. So chemo is rarely given alone as a standalone treatment, except for if they have metastases and we think, okay, I can't cure this, but we want to shrink it, get them feeling better. Or in the case, sometimes we give it up front to shrink the tumor, then we can operate on it. And then it's easier, or less damage to the surrounding tissue. Then there's this whole other field now called immunotherapy, which I don't know if you've talked about, probably.
We haven't talked about it, but it's fascinating.
Yeah, so there the idea is that there's something probably immunologic in your system that the cancer is actually shutting down and sort of escaping the immune system. And so about 20% of our cancers, if we give immunotherapy, it unlocks your native immune system to go attack the cancer, suppress it, and sometimes even keep it a long-term remission. So we're trying to figure out how to best use that in this context, but we don't know just yet.
Well, here's a question for you, because you work in the Bay Area. Do you see a lot of patients who are resistant to chemotherapy, radiation, because they want to go the natural route?
It happens, and I guess having practiced in Baltimore for 10 years, it's not that much different, maybe. I think often people will explore it a bit, but then when you have cancer and it's life-threatening, I think
people tend to wake up.
I think so, and or what we do is we integrate it and say, okay, these things are okay, but just don't take these drugs or these pills that you're not exactly sure may interfere with the treatment that we're giving. Or after you're done, fine, go do this.
So you're not discounting their angle, but you're saying, here's how we work together with that.
Yeah, absolutely, and saying this is what we know, this is what has been published. And so let's integrate this into the care that you're trying to achieve yourself. Yeah.
What's going on with Michael Douglas?
He probably had this type of cancer.
Wow.
Yeah.
Because he's doing better now, reportedly.
Yeah. But so, if you look at all the People magazine pictures of him,
which I do.
He lost a lot of weight. He looked really thin and emaciated, right? And so that goes to this treatment. Even though if we avoid surgery and just say, okay, we're just doing radiation, it's tough. It's really challenging, and so you need a team around them to really help keep them going so they can make it through the treatment. Yeah,
Catherine Zeta-Jones wasn't enough, you think?
She did pretty good.
Let's read some comments. Let's see. Okay, Bethany Thompson asks, she hears the HPV vaccine is only effective for 5 years or so. I haven't heard that.
No, actually, I think as far as we can tell, in fact, I think they're reducing the number of shots.
Yeah, they think it's actually pretty effective far out. But again, we have about 10 years of data now,
right,
which is not trivial, guys. 10 years of data is a long time. People are like, it's a brand new vaccine. It's like, it's been around for a decade, and we've been seeing how it's been doing. So let's see. I'm trying to find some good comments here. You can look with me if you like. Let's see, because they've been piling up. I would not and did not give my boys HPV vaccine, says Debbie Kolosik. I heard too many horror stories already. I will teach prevention and condom use instead. Should we talk about this? I think this is a great comment.
Condom use? Well, actually, so, as much as head and neck surgeons, we never thought we were going to be talking about, like, oral sex.
And now you're so excited that you are.
Now, like, all our conferences, we're sitting there talking about this. Like, I went into this because I wanted to stay above the collarbone. But our patients ask about it, and I think it's important to know that the behaviors that are associated with it are not just genital to genital sex. It's oral genital sex or contact is a real risk factor for this. So it's not just the use of a condom or barrier protection, unless you're using female barrier protection as well.
Which very few people do that.
Which is less common, right?
Yeah.
And then I think this is maybe a little bit off topic, but just one of the things that we also face if we don't talk about this is that people, if couples come in, let's say the man has tonsil cancer, we talk about HPV, and then invariably they leave after they get over the cancer part and they go, does this mean he was unfaithful? Because we've been together for 30 years.
Right.
Like, how is this happening? I'm not HPV positive. How did this happen? And so I always do make it a point to talk about that this exposure is something that happened a long time ago, that is not from last week or a year ago. But it can really be challenging because in the midst of all this treatment, then they have these thoughts of
STD thoughts, like this is an STD,
right?
And what's been going on? Yeah, interesting. Well, and that relates to. And by the way, Debbie Kolosik, the horror stories you're hearing are correlation, not causation. There's no evidence that the vaccine causes any of the things you've heard, and I would still strongly encourage you to, if they're not too old now, have your children vaccinated. And again, we don't give medical advice lightly here, but that's one that I will go on record and say for everybody. It's not individual medical advice. HIV co-infection.
Yeah.
Yeah. What happens in those cases? Do you see more cancers? Because the immune system is modulated differently? What's been your experience?
So I think some of it is that HPV-related head and neck cancer, 10 to 12,000 cases in the U.S. per year. HIV also relatively small. So the fact of the matter is that there may be a slight association with it, but we're not seeing this rapid epidemic of rising, oropharynx cancer in HIV-affected individuals. It may also be that a lot of the HIV is now being treated,
right?
And they're maintaining their counts, and so if they're in that situation, then they're less likely to have true immune suppression. Interesting.
Yeah. Lynn Boyd mentions that they know someone with baroreceptor damage from radiation causing permanent loss of pilot's license due to recurrent hypotension. So again, you always kind of think about what are the lifestyle, like what does this person do for a living? How will this affect their lifestyle?
Yeah.
Yeah.
That's fairly uncommon, but there definitely are people who, especially temporarily, they feel that way where they can't elevate their blood pressure appropriately. And again, this is one of those things that, for example, what we're looking at is, do we always have to radiate both necks? If we radiate just one, then theoretically, there's less damage to both sides,
right?
And things like that. So again, we're trying to look into ways to reduce and minimize the side effects.
Right. Carolyn Kozier worked as a nurse in head and neck surgical oncology for a time. This is a wonderful conversation. Thank you. Thank you, Pat.
Excellent.
Let's see what else we have here.
It's a small group of people.
It kind of is, right?
Yeah, and it's kind of nice because the nursing, the team, whoever it is, once you kind of dive into this, it's easy to get engaged.
Yeah.
And so we end up with a pretty small community of practitioners who are centered around this care. And it's sometimes, one of the reasons I'm here is that it's sometimes hard to get out to the world, like what it is that we do. Because it's not that common that you're going to have a neighbor who had this or, your best friend had this. It's fairly rare. And yet, my aunt had head and neck cancer. There are a lot of people that we can point to that we know that did have it. So getting that information. And, Patrick and I had lunch a few days back because, again, our families are friends, and your wife went to school with my wife, with Mrs. Dog, and she's a pediatrician. And
I was just telling him, oh, I do this show and this is what we do. And, he's like, oh, it'd be cool to talk at some point about HPV. And I'm like, wait, what? Tell me more about this. And I'm sitting there learning. And I told him, I said, look, if I'm learning a bunch of stuff, I bet the Z-Pack would want to learn. Yeah. And it seems like they do, to the tune of 500 to 600 live viewers in the middle of a workday. Right. Which, again, I am so impressed with your guys' engagement in trying to build Health 3.0. What struck me the most about what you said, especially in the beginning, is how you think very, and a lot of surgeons do think like this, but the stereotype is surgeons like cut, cure, get out.
Right.
You're like, no, longitudinal relationship, not just with the patient, but with an interdisciplinary team that manages all different aspects, including dentists and speech pathologists and physical therapists and everybody else that you deal with, respiratory as well.
Yep.
So to me, that is the future of how all of healthcare ought to look. It ought to look interdisciplinary, and we ought to be thinking about it in this way. And ultimately, the human beings are at the center of it.
Yep.
And you were like, oh, I never thought I wanted to stay above the neck, and you're talking about condom use.
Yeah.
So, and I mean, overall, do you feel pretty satisfied with your career choice and what you do?
Oh, no question. Yeah. I mean, it's a pleasure to take care of the patients. And then I think working in a team greatly enhances everyone's satisfaction. And so I think that's part of what's fun about being in an academic center as well, or any center where you have, a team-based approach, is that I think it would be very frustrating if you're kind of by yourself trying to manage this patient, because so many of their problems are out of your area of expertise. That you need help. And so it's sort of, it's a bit selfish that you say, well, I want this team because I need them.
Yeah.
Because I can't do it by myself.
That's how I feel.
No practitioner could.
Yeah. Nurses?
Everything.
Yeah. Because our nurses, man, it's like a lot of times they feel like docs, people in the hierarchy don't respect them, don't empower them.
Yeah.
We're forcing them to be epic click monkeys instead of practicing real critical thinking, which is what they're trained to do.
Yeah, so in fact, we now have 2 nurses on our outpatient side, and they have a lot to do with the patient education, management of issues that surround the patient. But I think we're trying to do a lot more preemptive education and prepare these patients for about what they're about to go into.
So Tessie Stansbury said, I just finished residency in oral pathology and I'm presently prepping for my boards. I'm a dentist by initial training and was drawn to this field. I work very closely with the ENT surgeons on rotations. I've seen this from both the dental side and the medical side. Thanks for doing a talk on this, and thank you for a great study break. We're always a good excuse not to look at the textbook.
That's a good question. Yeah.
Which one is that?
If a parent had HPV, can they pass it on?
So Shannon Mitchell, if a parent had HPV in the past, can they pass it on to their children?
Yeah, so this is, transmission is a good question. And again, we don't have all the facts of this, but a few things I'll tell people. One is that it is pretty rare for couples to come in both with oropharynx cancer.
Oh, interesting.
In fact, there's like case reports, which means,
rare.
It's so rare that you write about it and say, hey, I just saw this couple and let me tell you about their story.
Yeah.
So as most as we can gather, those are probably coincidental events. Like they both were exposed at separate times and then they happen to, be a couple in the future. So I don't, in general, we don't think of this as being transmissible at the moment. So if someone has tonsil cancer, we don't think of them as being infectious. So they're not going to, if you share their drinking glass or kiss them or use their toothbrush, it doesn't mean that they're going to confer that risk onto you. Because generally what happens is it's the component of the HPV DNA that disrupts the cellular machinery, but the infectious portion of that HPV is gone.
Yeah.
So you could get infected again and have tonsil cancer, but it doesn't necessarily mean that the infection has persisted the entire time that you're shedding virus. And so, to pass it on to your children, for example, if you look at the natural history of what happens, let's say if you swab the cheek of college kids and say, okay, well, when do they clear HPV or how do they get it? You can look at that and say they get it, and then usually 3 to 6 months later, it drops off. So it's like getting a cold.
Right.
Where you get it, and then you're infectious for a period of time while there's active virus, and then you clear it, and it's gone. So the only difference is then there's a component of that stays, but not the infectious component.
Yeah.
So that's as much as we really know, but obviously a lot of work is being done on this to figure out when are people at risk, why is it that they're in their 20s, when they seem to be at most risk for getting this. Interestingly, there's another group like in their late 50s that also have a higher incidence of HPV if you just go around and swab people's mouths.
Really? Oh, so it's like a second bimodal.
It is, and we don't know why. We don't know if it's, behavior. This guy might, maybe.
I've been trying. Sorry.
Yeah.
Yeah, well,
Yeah, I don't know.
let me ask you a question. So Are you going to vaccinate your kids?
Yes. No question.
I'm going to vaccinate mine. And he's got
Two
boys.
boys. Yeah,
Two
two
boys.
boys.
I've got 2 girls. And actually, they hung out and they're good buddies. They may get married. So you better vaccinate yours. I'll vaccinate mine.
Well, as long as you do, then I don't have to.
You're just assuming monogamy on the part of everyone.
Yes. Well, I know your children.
That's true.
They're good kids.
Well, and they're also going to be, I'm going to laminate them.
Yeah,
so
so
I'm going to
they'll be frozen
laminate
in
them from
time.
head to toe. Yeah, they're
Yes.
just going to be covered in plastic, so they'll be safe from everything.
There you go.
Yeah, unable to live, but safe. Man, Patrick, what a pleasure.
Yeah, it's been
We
great.
got it. So, guys, if you like this episode, we want to help Patrick spread the word about head and neck cancers, HPV, etc. Everything we talked about today. Hit like, hit share, send this to your friends. Go, this is the platform we want to hear about medical knowledge from, and we'll get Patrick back on the show if you guys want to hear from him. If you have questions for Patrick, ask them in the comments, and we'll see if he has a fake Facebook account that he can come on and answer. If not, he can scan through and get answers to me. If you want to reach him, message me, and I will try to connect you through the appropriate channels. If you have questions, if you have referrals, you want to make that kind of thing, we're happy to facilitate that. And again, we're here at UCSF Mission Bay. Like, it's beautiful.
It is nice here. Yep.
And you know, he really does love academic medicine, because we were walking around, he was giving me the tour, and he's like, look, you're an alumnus of this place, you should see this. Here's a research building, this is this, and they're doing this, and he was so excited. And I'm like, you know, it's great to see doctors who wake up every day, get up at the crack of dawn, come in all excited to see patients, care about what they're doing, care about other people. That is the opposite of what we intuitively seem to feel in medicine, where everybody's burning out and is miserable. Here's an exception, which means he's found his path, he's blazing a trail, and we can all learn a little bit of something from that and bask in the aura of it. So thank you, Patrick.
Anytime.
Again.
It's a pleasure.
And West Side, also East Side. It's cool.